Good morning, everyone. Welcome to the Drishti 2023, which is the 50th Golden Jubilee celebration. Today, the first IC is the Breaking the Refractive Barrier for Comprehensive Ophthalmologist. So, the main aim for this IC is to bring all the general ophthalmologists about the refractive surgery. Basically, it will be very simple IC. By end of this IC, you will take a few points how to set up a refractive surgery. I invite Dr. Rashmi for the first topic, who's fit for refractive surgery.
Good morning, all of you. First of all, I would like to thank the KSOS Scientific Committee, Dr. Srini sir and Dr. Aisha for giving me this opportunity. Here I am going to talk about who is fit for a refractive surgery. First of all, why should patient opt for refractive surgery? The most common indication is cosmesis. Some people will request for a refractive surgery because of spectacle or contact lens intolerance. Some may ask for an improvement in the unaided visual acuity and some for job recruitment. The fitness for surgery can be divided into three headings. First one is screening and history, then preoperative workup and ancillary test, and the last part is the counseling. Screening, always select patients above 18 years of age because that is the FDA approved age limit. They should be free from ocular comorbidities. They should have a stable prescription for at least 1 year, should not be pregnant or nursing. In the history part, ask about the age, occupation, trauma, hobbies, vision requirement, tobacco and alcohol use. Drug history of steroids, amiodarone, isoretinol and OCP is important. Systemic history of any autoimmune diseases, diabetes, PCOD, immunosuppression, atopy, epilepsy is significant. Always ask about ocular history of trauma, diabetic retinopathy, glaucoma, keratoconus, fuchs, herpes, Sjogren's, dry eye, contact lens use, RD, etc. The absolute contraindication for a refractive surgery include unstable refraction, ectatic conditions of the cornea, significant blepharitis or allergy, exposure keratopathy, uncontrolled glaucoma or uveitis, pregnancy and breastfeeding, single functional eye. Relative contraindications include dry eye syndrome, herpetic infections, diabetes, immunosuppression, autoimmune disorders, propensity to keloid scar formation and epithelial basement membrane dystrophy. Coming to the workup part. Start with the uncorrected visual acuity, best corrected visual acuity and near vision of the patient. Manifest and cycloplegic refraction is compulsory for all the patients. Dominance test can be done with the hole in the card test. Cover test is important because asymptomatic tropia or phoria can become symptomatic after the procedure. Slit lamp examination should look for any infections or inflammation of the lids, conjunctiva, cornea. Also check the pupil and the lens. Fundus evaluation to look for any pathologies in the optic nerve, macula and in the retinal periphery. Pupil size should be measured in bright and dim illumination. IOP and gonioscope is also important. IOP can be raised during suction in the LASIK because of postoperative steroid use, and also false low values are expected after refractive surgery. Tear film analysis is done with Tibet and Shermer. Orbit evaluation is also important because sunken eyes and prominent eyebrows can give rise to difficulty in LASIK. Coming to the ancillary test. Keratometry is important because flat corneas less than 40 increase the risk of free flap and steep corneas more than 48 increase the risk of buttonholing. Excessive flattening or steepening after the procedure can result in poor quality of vision. A steepening of 1 diopter for every diopter of hypermetropy is expected and a flattening of 0.8 diopter for every diopter of myopia is expected. Coming to the corneal topography and tomography, it helps in detecting early and suspected cases of ectasia and also helps in planning topo-guided custom ablation. Eyes with visually significant irregular astigmatism are not generally good candidates for refractive surgery. In the topography map, always look for the elevated points in the anterior and posterior elevation map, whether they are correlating with the highest power in the sagittal map and the thinnest point in the pachymetry map. Special attention should be paid if there is significant posterior corneal elevation or a bad score more than 2 in pentacam. When keratometric and topographic astigmatism is significantly different from the refraction values, refraction should be rechecked. It can be due to lenticular astigmatism or posterior corneal changes. Coming to the pachymetry, this helps to decide the most suitable treatment for the patient, whether it is surface ablation, thin flap LASIK or SMILE. CCT less than 480 microns and RSB less than 280 to 300 microns is considered as a contraindication. Coming to the ectasia risk, percentage of tissue altered is calculated as flap thickness plus ablation depth divided by CCT. So a PTA value of 40 or above is considered as high risk of ectasia. Ectasia risk scoring system by Randleman consists of parameters like topography, RSB, age, CCT and mean refractive spherical equivalent. Points 2 or less is considered as a lower risk of ectasia, 3 for moderate risk and 4 is considered as a high risk of ectasia. Roughly, one diopter of ablation removes around 12 microns of stroma. The amount of stromal tissue removed depends upon the optical zone and the magnitude of refractive error. So the ablation depth is equal to diopters of correction into optic zone diameter square divided by 3. Residual stromal bed thickness is important. It is calculated as CCT minus flap thickness plus ablation depth. A minimum of 280 to 300 microns is necessary. Contrast sensitivity can be checked using grating tests like VSTEC and optotype tests like Pelli-Robson chart. Wavefront analysis provides an objective refraction measurement. It is used to refine the manifest refraction. If the manifest refraction and the wavefront analysis are very dissimilar, the patient is not a good candidate for wavefront treatment. It is particularly important in irregular corneas, post-cataract and post-refractive surgery retreatment and high astigmatism. It also helps to plan custom ablation, aberration, neutral treatment profile. Custom wavefront ablation generally removes more tissue than standard ablation in the same eye. This is an example of the preoperative worksheet in a LASIK patient. It should have AR values, K values, axial length, CCT, PG power, final refraction, pupil sizes, white to white, postoperative K values, cover test, anterior chamber depth and gonioscopy, specular microscopy and Shermer. Coming to the most important part, that is the preoperative counseling. The patient should be explained that they can expect only the best spectacle corrected visual acuity. They should be explained that this will not alter the presbyopia or cataract that can happen in future. Procedure of monovision correction should be properly explained. Always assess the patient's expectations. Explain realistic goals along with rare chances of complications of treatment. A good candidate is one who, despite of expecting improved vision, would still be okay with the idea of having to wear glasses under certain situations, such as when driving at night. For more apprehensive patients, we can show them the recently published data on the safety and acceptability of the refractive surgery. Also, display your credentials prominently in your cabin for the patients to see. Involve parents and attenders in the counseling process, which helps to build trust and rapport. Always promise less and deliver more. So to conclude, careful patient selection and a well-planned treatment can always produce happy patients. Thank you.
Now we'll move on to the second talk. Who is fit for refractive, surface ablative versus flap procedure, what to do and not to do. I invite Dr. Aisha. She's a refractive surgeon at Srikanth Eye Hospital, Kozhikode. Over to Aisha.
Thank you, ma'am. Good morning, everyone. I would like to thank KSOS and the scientific committee for giving me this opportunity. Today, I'll be giving a brief explanation about surface ablation with flap procedure, in that what all we should do and not to do. So we all know there is three types of refractive error: myopia, hyperopia and astigmatism. Same way, we have three modalities of treatment of refractive error. In that, eyeglasses and the contact lens is a temporary mode of treatment. That is, once the eyeglasses or contact lens is taken, you will have a blurring of vision. For that, we have a permanent treatment method called refractive surgical procedure. So in the refractive surgery, we have two types, that is a lens-based procedure and a cornea-based procedure. In the cornea-based procedure, I'll be mainly discussing about the tissue subtraction method like a surface ablation like LASIK and a stromal ablation like surface ablation like PRK and a stromal ablation like LASIK. So the main mechanism here, the refractive surgery or the laser, is photoablation. That is, it breaks the carbon-carbon molecular bond in the stroma and thus it reshapes the corneal surface. Excimer laser used here is the argon fluoride excimer laser with a flying spot size of 1 to 2 mm, energy of 100 to 300 millijoules and a pulse of 100 to 1000 Hz. Whereas photodisruption is mainly done for femtosecond laser for creating a corneal flap. So before going for refractive surgery, you should attain a certain rules. That is, always set a realistic expectation. Time taken for vision to improve, especially in PRK patients. Minimum you have to tell them 3 to 4 weeks to get a crisp and clear vision. Dry eye. In the preoperative method, if patient is having dry eye, tell them the need of long-term lubricant, especially those patients whose screen time post-surgery is 5 to 6 hours. Tell them they have to use preservative-free lubricating drop for another 3 to 4 months. And refractive predictability within plus or minus 0.5 diopter before the surgery itself, you will tell the patient. The need for presbyopic glasses, and the most important is the patient cooperation during the procedure. And 5 points when patient is in the intraoperative, under the table, 5 points you should tell before itself. Before a patient is counseled for PRK or LASIK, explain to the patient what is PRK, what is LASIK, what procedure you are doing for PRK, what procedure you are doing for LASIK. First point is touch. Patient, tell them, though we put a paracaine to the patient, you will feel a touch, but they will not have a pain. Especially when the suction and the blade movement, patient, tell them you will have a feel of touch. Sight, when the patient is under the machine, tell them to look on the light or the red light or the green light. Once it is focused, tell them you should not move, because during suction process there will be slight blurring, so chances of patient to the light move and focus to the light is more. Third, sound. Tell them you will hear a sound of a blade sound or excimer laser sound. Nothing to panic, just tell them to calm. Smell. Nowadays, because of the latest machine, you will not get that burning smell, but few machine you will get that excimer vapors burning smell. Calm mind. That is the most important thing. Before coming to the OT, ask the patient whether they have a claustrophobia. If not, it is good. If, tell them nothing to panic. Procedure hardly takes to 10 to 15 minutes. Before starting the procedure, make sure your patient is calm. Now I'll be dealing with photorefractive keratotomy. That is, by using the excimer laser, we mainly reshapes the anterior surface of the cornea. So who are fit for PRK? Any low to moderate myopia with 6 to 8 diopter, low hyperopia up to 3 diopter, moderate astigmatism up to 4 diopter, thin cornea where RSD is less than 300 micron and are not fit for LASIK, deep orbit with suction is not possible in LASIK, flat K less than 40 and a steep cornea greater than K 48 where the blade complications or a flap complications will be more. Any sports person or occupational person like Navy, Army where chances of flap trauma is more, and any enhancement procedure. So surgical step combining with PRK and LASIK, here the most important part is the epithelial removal. That can be done by mechanical, where manually we are scraping the epithelium by using a hockey knife, or chemical by using 20% ethyl alcohol, and the latest technique is the laser method. Once epithelium is removed, we'll do the excimer laser ablation. After that, we have to apply mitomycin C for 30 to 40 seconds depending upon the refractive power. This mitomycin C is thoroughly washed with balanced salt solution. Finally, we have to place bandage contact lens with appropriate antibiotic coverage. So the first picture you can see, that is alcohol well, where alcohol is put 20% for 20 seconds. Second picture is a trans PRK, where laser itself will take the epithelium. You can see a clear margin while combined to the third picture, where we are removing manually. This is a small video how epithelium is removed by using alcohol. That is an 8.5 mm gauze piece, absorbed gauze, soaked with 20% alcohol. I'll be placing for 20 seconds. This is 20 seconds. Then delamination of the epithelium will be done. Slowly by using hockey knife, gently remove the epithelium to get the clear 8.5 margin. Make sure you should not force or you should not apply force in this. Sorry. This is how epithelium is removed. Once this epithelium is removed, the next step is the laser ablation. So in this, before going for laser ablation, what you have to do is the iris registration. The benefit of this iris registration is there won't be any decentered ablation if the patient moves the eye a little bit. So once this is done, excimer laser is given, then a mitomycin C will be placed, a thorough wash is given, and a bandage contact lens is placed. So what are the post-operative care? Do not touch or rub the eye. Follow up post-op medications properly. No face wash or a hair wash for 5 days. No eye makeup for 2 weeks, and no swimming in lakes, beach, pool for 1 month. So next is LASIK or femto. Both are flap-based procedure. In LASIK, to take flap, we will be using microkeratome, whereas in femto, we will be using laser. So flap-based procedure is mainly done myopia up to 8 to 10 with the proper corneal thickness, astigmatism up to 6 diopter, and hyperopia up to 4 diopter. So this is the most important step in LASIK, the selection of the microkeratome. We have a different types of microkeratome. So always try to keep the K mean around 40 to 46. So less than 41, there is a chances of free flap. Greater than 46, there is a chances of buttonhole. Thinnest Pachy, it should be 500, and the final RSB should be always 300 microns. This is a small video. Once a suction is given, this is how the blade is moving. That is a forward movement. And same way you will have the backward movement. So once this is done, carefully we have to remove the instrument, and the next step is the flap lift. So after the blade is given, you can slowly go under the flap, lift, keep it in the tacho fold. Once this is done, go for the excimer laser ablation. Keep the flap opposite and a bandage contact lens. Make sure the flap is aligned properly. So femto-LASIK means femtosecond laser will be there for the flap creation and excimer laser for the stromal ablation. Here main difference is we have to dock the patient eye with the cone. So this is the docking of the patient, this is the cone size, and the cone size depends upon the wide to wide measurement of the cornea. So post-operative complication, pain, PRK, especially in PRK. Before going for surgery, explain to the patient pain, watering, photophobia, redness. These 4 symptoms persist for 3 days. Second is epithelial problem. Next is corneal haze. And intraoperative complications like free flap, buttonhole, flap tear, epithelial ingrowth, debris, microstriae, infectious keratitis. Dry eye is the most common problem, especially seen in the LASIK. We go for preservative-free lubricating drop. Glare, halos, and starboard. This is other most complications seen in the LASIK. Decentered ablation, overcorrection, undercorrection, and regression is another complications of LASIK and PRK. So finally, I am ending. PRK can be done with thin cornea, high keratometric reading, narrow palpebral aperture, patient at a high risk of blade trauma. LASIK myopia up to 8 diopter, hypermetry up to 6 diopter, astigmatism up to 6 diopter, and residual refractive errors after cataract surgery and PK. Thank you.
Thank you, Dr. Aisha, for that excellent presentation. Now I invite Dr. Vijay Lakshmi. She is the consultant cataract and refractive surgeon at Comtrust Eye Hospital, Calicut. She will be talking about phakic IOL, pearls and pitfalls.
Good morning, everyone. Let me thank Dr. Aisha and Ashmi for including me in their IC. And I'm very happy to present this topic in presence of Dr. Krishna Prasad, who was a man behind this to make us do this phakic IOL, and Dr. Sujit, who was a support when I did my first phakic IOL. Now, Dr. Aisha said lots of problems whom we can't do and complications. So in such patients, why don't we start with a phakic IOL? So I'll be talking about posterior chamber phakic IOL, which is implanted in the sulcus in the presence of a natural crystalline lens to correct refractive errors. So a few words about the phakic IOL. What are the advantages? It's far from the endothelium, placed in the sulcus, excellent cosmosis, and close to the nodal point of the eye, and it gains retinal size image, safe placement, and in case this is a problem, you can remove it easily, exchange it. It is not fixed to any tissues and does not alter the shape. The cornea remains as a virgin cornea. That's a very important thing. Now, as Dr. Aisha had mentioned, lots of people whom we cannot do this refractive procedures on the cornea, like in thin corneas, high refractive errors, patients with flat K, steep K, and we also have off-label use in keratoconus, in stabilized central cones. We can go for phakic IOL, and the age group is from 21 to 40. Some people demand even after 40 years also. Now, what are the prerequisites? They should have a stable refraction, clear crystalline lens, anti-chamber depth of more than 2.8 millimeters, very important, and endothelial cell count of 2,500 above, no corneal or ocular pathology or retinal pathologies. And people whom it is contraindicated is where they have a progressive refractive error, corneal, especially endothelial pathology, glaucomas, any evidence of cataract or capsular opacification or any retinal pathology. Now the materials available are, one is a collamer and the other is made up of, Indian lenses are made up of acrylic hydrophilic material. These are the lens designs available. You have a pointer? Okay, this is a very important thing within these holes where you have the aqueous outflow tracts. Now I'll be talking more about the Indian lens and which I am more experienced with. That is a biconcave monofocal design made up of hydroxymethyl acrylate. It's a single piece hydrophilic lens, and the central vault is very important thing. Of 1000 to 1600 microns, there is no lens touch. And it's got a 2 peripheral holes and 1 central hole for the better aqueous flow. Initially this hole was not there. We used to do peripheral irectomy. Now once the hole has been, they incorporated it. Now we don't do peripheral irectomy, and it comes in 0.25 steps. That's a good thing about it. And you got a wide range for myopia and astigmatism. Very, very important parts are the AC depth, which is very important in doing the phakic-IOL calculation. Similarly, the white to white. Keratometry, as in all refractive procedures, should be done methodically and precisely. Yes, now we'll just see how the white to white is measured. It's a very, very important thing. The patient should be in the supine position under the operating microscope, anesthetize, and take the mid-limbal value. That's very important. From the mid-limbal, from above superior as well as from the inferior. We can just verify it from both sides. And I do with digital calipers. Of course, we have IOL master, pentacam, but the best thing is to do with the digital calipers from the mid-limbal area. Now we have a patient with, this is a refractive power. What can we do for her? This is a pre-op investigations, Vector cycle bridging, very important, biometry, topography, specular, applanation, gonio, white to white is very important, slit lamp evaluation and retinal evaluation. This was the best corrected visual acuity with glasses. And this was her AIC depth, which is very much above 2.8 millimeters. We did a specular and lens thickness. We also want to know the lens rise also, and axial length is also measured to, so in case patient develops a post-op refractive errors, again to know if it's a pathological myopia, we must have a baseline axial length measurement also. This is a topography, rule out any posterior problems in the cornea. And this is a pre-operative workup we sent to the company, and this is what they sent to us. This is our armamentarium. I do it under topical anesthesia, and I also use Oclan just prior to insertion. So an incision, I'll just start with the lens loading. It's easy to load. The lens is very easy to load. Just take it, and learning curve is very, very less in this lens loading. First, the cartridge should be thoroughly washed with distilled water, and then use the BSS. Then you can put Visco and load it. Just gently tuck it into the cartridge. And make sure in this, see, the haptics are well inside the cartridge, so it doesn't get engaged in the plunger. Make it 2.8 to 3 mm incision. 2 side ports are made. I first use Oclan followed by Visco. Don't overfill the chamber with Visco nor underfill it. Optimize it, and then side ports are made. You can incision assisted implantation is good. And one thing you must be careful, the IOL doesn't flip, the phakic IOL doesn't flip, so you can support the dialer so that it doesn't flip off. And ideally you can place it over the iris. Make sure that it doesn't graze over the anti-lens capsule and cause any opacification of the capsule. And once it is gently tucked in, you can go for an thorough washout of the Visco. Be careful, the irrigation should not be directed towards the anti-lens capsule, because that can produce anterocapsular opacifications and vacuolization. Similarly, some people do it under irrigation also, implanting it. But I would advise only under Visco implantation, because this irrigation can itself cause anterocapsular vacuolization. See, you can wash it using through all the ports. 2 peripheral ports are there. You can use irrigation there and irrigate it thoroughly and remove the Visco. And following that, we intracameral Oromox is used, and the side ports are hydrated. This is first post-op. Always check the intraocular pressure and vault the next day. The ideal vault is 250 to 750 microns. Half cornea width to 1.5 times of the corneal thickness. This is a happy patient. You must be very, the next second the lens vault, something very important, you must check it. See, this is an ideal vault. Suppose you have a vault like this is an oversized phakic IOL. In this case, you have to reduce the size. Here you can see the cataract developing due to flat touch because of a flat phakic IOL. And this is a vacuolation mentioned about. Usually it resolves within 1 to 2 weeks, but sometimes it can remains. So that irrigation bar should be very, very careful when you're doing a phakic IOL implantation. Initially we used to do PI when there was no central hold, and oversized lens producing high volt and undersized lens producing a low volt. Now this patient, this is a refractive BCV of the patient. Her retinoscopy was -10, but she was using only glass power of -8.5. So in such patients, what you must do is give the full correction with a contact lens. And this being an anisometropia, we had to give contact lens, give the full correction, check her anterior chamber depth, this is fine. Now she's got a squint also. So once she uses a complete correction, her squint improved, and she had an IXT, now it's improving. They're waiting for review. So in toric phakic IOL, good thing about this, it's just implanted 0.18, you don't have to do any rotation. That's a good thing about it. Again, post-op vault and IOP is very, very important. This now, the next thing is now patients are coming who have already been implanted with phakic IOL, coming with cataract. So in such patients, it's very easy to remove the lens. You just have to hold the optic haptic junction and remove it, and this is a IOL we have removed. But just keep the specular count, just follow up the patient on that. This is another patient who has cataract with the peripherectomy and phakic IOL in situ. This patient also underwent cataract surgery, and we implanted a toric IOL for this patient. He had keratoconus also. Post-LASIK ectasia, C3R done, implanted, and toric IOL was implanted. He had a myopic schisis, and this is another case. The patient had a blunt trauma, and the haptics, one side the haptics are outside. You can see the lens vault. And this is over. You can just dilate it and you can replace it. So it's if it is undersized, we have to go to the next size. If it is oversized, again reduce the size. You can just expand it, the heel on and pull it out. And this company, they provide with 2 lenses. The surgeon is comfortable. So we have done around 200 this lens and some few ICLs only and other IPCL only. And the highest power we have implanted, and this is a toricity we have implanted. So it's one of the most simple intraocular surgeries, but with precise preoperative evaluation is very, very important, and give one of the happiest patients after the surgery. And the quality of vision is always better than promised. Thank you.
Thank you, Dr. Vijayalakshmi. I think in fact you were mentioning about the high vault and the low vault. Basically, high vault means more than 1000 micron and the low vault is less than 250 micron. So high vault causes glaucoma, it causes a narrowing of the angle, and low vault causes the cataract formation. So the measurement, if you think that there is already high vault post-operative day 1 more than 1000 micron, so what we can do in case of if you are not implanted a toric phakic lenses, then you can rotate to the vertical, because as we all know that vertical white to white is more than the horizontal white to white. I think sir do agree with that.
Yes.
So in case of high vault with the toric implantation, you can't rotate because you may have problem. In such cases, maximum wait till up to 1 month. Then I think you should always plan for exchange phakic lenses. Then you even nowadays with the center hole, I am talking about the star. I don't have any financial interest. Even we have kept up a lens. We even vault of around 125 also. Because of this center hole, the chances of cataract is much lesser. There are patients are coming for follow-up for more than 3 to 5 years. Still, you don't get any cataract with the center hole. Of course, I don't have, actually I am the first person to implant this lens RAL in one live surgery in Kolkata. We have done some small study between this Collamer versus any of this acrylic material. What I feel that Collamer and acrylic material is same. Even though they call it as that is Collamer, that is also basically acrylic material with a Collamer coated lenses. What people say that after the implantation, after a year, normally the property of the columnar goes off within the eye only. It is as if like the similar to that. The only advantage with these star lenses are it is much thinner compared to these lenses. So chances of complications are much lesser with the star. Okay, over to you, sir.
A very good morning and thank you for giving me this opportunity. Thank you, Dr. Aisha. The topic I'll be discussing will be the refractive lens exchange, the tips and the tricks. So, what is it? It's just a glorified cataract surgery without cataract, because the indication here is not just removing the cataract, but for the correction of the refractive error. This is an old wine that is being delivered in a new bottle. This was there very long ago with the term clear lens extraction, but now the lens need not be clear always. And not only that, we are actually doing it for a specific purpose of giving us spectacle independence, and we are fortunate to have advances in the phaco-dynamics and better intraocular lenses that we can provide it. But are we justified in doing this? That's the question. So we need to understand some relatively newer concept, that is the dysfunctional lens index. So when we speak of lens, we always think about the transparency of the lens, but when we look at the lens as a functional organ, there is some other functional loss also that happens before the transparency is lost. That is being quantified as stage 1 and 2 in dysfunctional lens index, where the lens flexibility, the quality of the lens, the quality of the light that is being transferred through the lens, that is by checking the scatter as well as the transparency of the lens. So these are the patients where we sometimes find in the OP, they come to us, they may be having 6/6 vision with best correction, but they say as they age, they feel that my vision is not as good as it used to be in the younger age. So it is being quantified, and it is quantified as normal, moderate and severe. When the lens index is less than 5, it is supposed to be severe because the quality of the vision they perceive is very bad. Based on this, the lens function quantification, now the term better used is dysfunctional lens syndrome, in which they take the presbyopia, higher order aberrations, as well as the lens opacities or the loss of transparency into account, and they have graded into grade 1 and 2, grade 1, 2 and 3. And in this, the grade 1 and 2 are those category of patients which we call as the pre-cataract or early cataract, and we try to find a solution for them because the quality of vision is not clear. So putting that in mind, the actual term that is proposed now is the dysfunctional lens replacement for the refractive lens exchange. Just an example which I am quoting from an article, a 42-year-old gentleman with a clear lens who came with a similar complaint of not a happy vision. Looking at his eye, they found that everything is normal, the lens is clear, even the pentacam nucleus staging is showing no opacities, but the lens index is showing very severe value, the value that is in the very severe range, that is 2.56, which probably explains his dissatisfaction with the vision. The ocular scatter index is the index that quantifies the light scatter then when it passes through this dysfunctional lens. It is again color coded in green, red and yellow with the values given for it. It is measured by a double pass aberrometry approach. And high ocular index, one thing to be kept in mind is that you may have corneal as well as tear film anomalies affecting the ocular surface index. So coming to the primary indication, as we all know, 40 is the age, landmark age in ophthalmology, which creates a lot of change in the refractive error. So anything less than 40, people with high refractive error, either myopia or hyperopia, because of the abnormal ocular anatomy, and who are not good candidates for phakic IOL or refractive surgery, laser refractive surgery, are probable candidates for refractive lens exchange. And above 40, anyone with presbyopia, with myopia or hyperopia, who is wishing for a spectacle independence. So this is one case I recently did. The summary of the patient is like it's more than 50 years, female, hyperop, presbyop, non-diabetic, relatively clear lens. One more case, lesser age group, 40 to 50, 46 years, female, hyperop, presbyop, non-diabetic, done for a professional requirements. So what I look for, or a comfortable patient for me, would be a middle-aged female, more than 50 preferably, a hyperop with presbyopia who is wishing for a spectacle-free life with or without cataract, and There are no other ocular or systemic morbidity that may complicate the vision later onwards, and who may not have much problem with multifocal lenses like less night driving. But I am also concerned about taking away the God-given gift of loss of accommodation when I'm doing it at an age of less than 40 years. And I'm touching an eye which can be refracted to 6/6. So I don't want any other errors from my part, and it should be a zero margin error from the surgery point of view. So I should be comfortable doing a proper IOL power calculation. I should be sure that he or she will be good, well neuro-adapted to this multifocal lenses, and there should not be, I will not be creating any other retinal complications. So, special consideration, I am more comfortable in hyperopic patients. There are not much of things which I need to take care of, except for the less space in anterior chamber or a probable primary angle closure predilection. Or, see, if you are comfortable with your cataract surgery, probably you can take care of these things. And literature also supports that your cornea safety is better than phakic IOLs in a hyperope, and your higher order aberration profile is also better with refractive lens exchange than hyperopic LASIK. Case 3 is slightly different. It's more than 50 years, but the patient here is a low myope with astigmatism, with presbyopia and non-diabetic. So this is the age group, around 50 is the age group when the myopes start feeling the heat of presbyopia. Low myope presbyopes is a difficult category. They will not be happy with any of these procedures. What I'm saying is that between 40 to 50 years. So what happens is, if with the LASIK, they will be happy with the distance vision, but they are losing the near vision. With the monovision, they are compromising the depth perception. With the refractive lens exchange, they may not be very happy with the multifocal lenses because they used to get a very good near vision without that. So myopes is a different ball game. Less than 40 years, you have to think of options, phakic IOLs, LASIK or PRK. Above 50 years, refractive lens exchange would be a better option. Between 40 and 50, you have to be really careful, because these are the patients who will not be very happy. Special consideration in myopes, obviously the retinal evaluation is very important, and these are the patients whom we should not do refractive lens exchange in myopia, the patients with the retinal periphery degenerative changes or myopic changes. RD, by all matter, is very important consideration. There is almost 8% incidence, especially in the patients with higher more than 10 diopters of myopia and axial length more than 26. We know what are the risk factors. Even a post-operative PC YAG cap also increases the risk of retinal detachment. The literature says that the incidence is more than double in a myope of the same quantity myope who has not undergone a surgery. So, chair time and counseling is very important when you are taking a patient up for the refractive surgery, refractive lens exchange. You have to explain realistic expectations, the durability of the vision that will be recovered, the possibility of the other changes that can happen in the later life, the multifocal related issues, and alternate options should be discussed with them. That includes the phakic IOL and laser vision correction. Or in fact, if it is in that 40 to 50 years, you can even tell them to wait for a little longer time for a better surgical result. And when you are comparing with phakic IOLs, you in phakic IOL definitely have a better advantage of reversibility and can maintain the accommodation, but a further intervention is definitely indicated in that when they become older. If it is with the laser refractive surgery, okay, better accepted, and chance of regression is there in laser surgery, but the higher order aberrations make them little less place than the refractive lens exchange. And a laser patient, once they become glass free and later they become cataract and they develop cataract, they may not be a good candidates for a multifocal at later stage, though happen to be wearing glasses at a later stage again. So general principle, what I follow is less than 40 years, high myopes, phakic IOLs, moderate myopes, refractive laser refractive surgery or phakic IOL depending upon the indication, and avoid refractive lens exchange. Presbyopic age, above 40 years, 40 to 50 years, hyperopes, I prefer refractive lens exchange. Lower myopes, either LASIK with near vision glasses, monovision or planned undercorrection as per after the discussion with the patient. Or high myopes, go for phakic IOLs or in selective cases, refractive lens exchange. More than 50 years, refractive lens exchange is my choice. So it's the same thing in a diagnostic flow chart. which should be discussed with the patient. The critical steps are counseling, a proper IOL selection, very accurate IOL power calculation, perfect astigmatism-free neutral surgery, zero tolerance for mistake, anticipating and avoiding all possible posterior segment complications, and giving a good tear film balance post-operatively. Intraoperative consideration include, it should be considered as a premium surgery, giving patient all the best possible things during the surgery under topical anesthesia, perfect astigmatism neutral micro-incision surgery, well-placed, perfect centered rexus with good cortical cleanup and PC polish. PC polish is very important because you want to avoid a yak cap at any point of time later also as much as possible. Well-centered IOL and a post-op anti-infective regime. IOL selection, nothing much, but very important that you need not always go for a multifocal lens. It's the patient's choice, what is their expectation and what is the lifestyle. So you can choose between monofocal and multifocal even in refractive lens exchange, but toric IOLs always give the option of giving in astigmatism always give the option of giving a toric IOL. You need not target emmetropy in all cases. You can even plan a myopic correction depending upon the patient lifestyle. You are always, most of the cases you are dealing with extremes of axial length. So you have to be very careful about using adequate formulas for an accurate IOL power calculation. And multifocal lenses, they do well as per literature even in refractive lens exchange. And to summarize, it's a very predictable surgery result with latest IOLs and machines that we have. It has got a wide range of, it can deal with a wide range of patients. It can be a one-stop correction for all types of refractive error. And our targeting, what we are targeting is a complete refractive perfection for that patient. No specific training is needed for this, for those who are already trained for cataract surgery, and more or less stable vision for a very longer period. But patient age, profession, personality, lifestyle, and expectations are to be considered, discussed with the patient, and finally, select the right procedure should be selected. And as we all know, there is no urgency in it. It's an elective procedure. So we have to ensure the best possible result with the highest accuracy, durability, with the least risk that is for that particular patient should be chosen. Thank you very much.
Thank you, Sujit sir, for the detailed and updated presentation. Now I invite Dr. Krishna Prasad Kudlu. He is the Medical Director of Prasad Nethralaya Group of Hospitals, Member Scientific Committee AIOS, and Editor Proceedings 2023. He is an excellent cataract and refractive surgeon. He will be talking about SMILE and beyond, recent advances in refractive surgery.
Thank you, Dr. Rashmi, and thanks again for including me this wonderful instruction course. Thanks, Aisha, and all the senior consultant, my dear friends from Kerala. So I'll be talking about the SMILE and future. I don't have financial interest for this particular talk. So as we all know that laser refractive surgery has evolved in like a full circle. It started with surface ablation, then later on we started doing LASIK, then later on we doing a customized wavefront guided treatment, then again we are doing femtolasic, then SMILE, then again what Aisha told about, people are started doing more and more now surface ablation. People think that it has got more advantages. So coming to the Relix SMILE, it is a combines of a femtosecond technology with a high precision lenticle extraction, aiming at providing minimally invasive refractive correction. Basically, it's a flapless procedure. So advantage with this Visumax femtosecond system, because of it has got a high pulse repetition rate, so the short procedure time, then the low and very stable laser energy, that gives a excellent cut quality also, and very good incision size. Then as we all know that always Zeiss provides with a very good microscope, so the depth of accuracy is pretty good. So coming to the corneal interface design, that they made in such a way that it eliminates almost most of the artifacts, minimum discomfort to the patient. Basically, it's a one-step docking procedure. And nowadays, even it has got automatic centration also. Coming to the contact lens, what we use in this Visumax is more towards as a shape of the cornea. So it gives a minimal applanation with a very low suction pressure. So the advantage of with this femtosecond laser is very minimal IOP increase. So you can, the lot of advantage for the patient, and also there is no vision loss during the suction. So basically a refractive lenticle is created in the intact cornea which is removed through the small incision. So single step procedure, due to that very early visual recovery. This is about the machine. Uh, so about the incision, you can do from 1 to 4 mm. Beginners, I always tell them to start with 4 mm. They can come down up to 2.5. Even I have done up to 1 mm incision also. So a lot of studies shows that better biomechanical stability compared to the femtolasic. So as I already said that it's a soft and safe suction. So you need not have to worry about that. There is no noise at all, and also less post-operative red eye. Basically, very easy to maintain this machine. So also patient can get back to their work very immediately. Excuse me, the procedure. Can you? Yeah, thank you. So this is about the procedure. Normally, it starts with the lenticule cut, then with the side cut, then with the cap cut, then with the incision of 4 mm. So normally first identifying the different layers are very important. First you identify the superficial layer, then you identify the deeper layer, then you dissect the cornea, something called a windshield wiper movement. Now once you open this deeper layer, dissect in similar kind, make sure that the lenticle is free, then you can take out with the help of any forceps and put it over the cornea to see for the integrity of the lenticule. I'll just show you, take you just a couple of, will you play this video if you don't mind? Just not take much time. When time is over, Rashmi, please tell me, I'll stop that. Will you stop the music? So normally this procedure is, I myself being a surgeon, I explain to the patient, I sit with them how exactly he has to behave during the procedure. So once you tell that how exactly you have to behave, then put the patient under the microscope. Then optimal 1 or 2 drops of anesthetic drop is more than sufficient. If you put more, sometimes epithelium may loosen up. Then always being a surgeon, I myself check the parameters in the machine, make sure that it is the same patient data has been entered. Once it is done, then machine start calibrating for that particular patient. Once this is over, proper draping and application of the speculum also very important. Make sure that there is no eyelashes coming in on the way. If you are having eyelashes, sometimes you may have problem. That area may not have any treatment at all. So adequate wash of the ocular surface and the fornix is very, very important. Make sure that conjunctiva is fully dry, but cornea always you should keep a semi-moist. If you keep cornea too dry, then you may have some black spots. Head positioning also very, very important. The patient with a longer nose, always you have to tilt towards the opposite side. Make sure that you will have a proper laser treatment during that time. Connecting the appropriate size cone also very important. Patient with a, always take the cone from your right hand, plug into the machine, and then you can hold for right eye, hold it in a right hand, go to the slot, then lift a bit, you will hear a click noise. That means the machine will start calibrating for that particular cone. White to white lesser than 12 mm, always nowadays we are taking smaller size cone. Then in such cases you apply it only 80 to 90% more than sufficient. Only white to white more than 12, then you take medium size cone, there you have to do 100% application. Then I will not be showing about the flex and all, this is will take more time. Can you run the video? Can you run please? Yeah. Okay, I will not show the complication because of the permitted time. So these are the advantage with the relic smile. Less energy on the cornea when you compare with the femtolasic. So especially it is very good for high myopia, better results. Higher stability of the treatment. So lesser induction of the spherical aberration. Very important, larger effective optical zone. So lot of study shows that it has got a higher biomechanical strength. So chances of ectasia is much lesser. There are hardly few ectasias in the smile in the last so many years. So there are some issues with the Visumax 500. One is the cyclotorsion compensation. Second one is still they are not come with the hyperopic correction. And of course, astigmatism was treating astigmatism was a problem, and also centration issues also. This has been overcome by this Visumax 800. Now they are come with the cyclotorsion compensation. Soon they are coming with hyperopic treatment, faster performance, smart robotic assistant, and reduced laser time. Of course, it is digitally connected to the total Zeiss workflow. So compared to the femtolasic, always better vision quality, larger effective optical zone, and lesser induced spherical aberration. So always, since it's a very expensive machine, you have to market it in a big way only. Always you should promote it as it's a new way to correct a refractive error, not as a new concept. So communicate that it is not a new technique, but is much more it is an accurate, predictable, and safer treatment. So how we normally promote in our center, basically it's a bladeless, flapless, all femtosecond laser procedure, which has been a laser technology awarded a Nobel Prize in 2018, which is also FDA approved. So different way you can market this machine. So smile must be promoted as a new way to correct a refractive error, not as a new concept. Because as the concept of reshaping the cornea to correct the refractive error has been there for more than 2 decades. So take home message, I am a true proponent of this refractive technology and has been tremendously benefited to my center. Probably our center is the only one center in coastal Karnataka having this treatment. Till that I have done thousands of smile surgery. It has been a sweet ride for me. Thank you.
Thank you, sir, for that explained presentation on smile. Now I request Dr. Vijay Lakshmi Madam to hand over a token of appreciation to Dr. Krishna Prasad, sir.
Actually, thousands of cases, hardly one or two patient came with regression. Only one or two patient, but so far touch wood, there is not even a single ectasia faced in my cases. As you showed that your chart, that this age till 40, what you have to do, we are very much following the criteria. Even though company says that you can do smile with -10 with 4 cylinder. Now they are going to come with the -14 license also. Even though Paki is of around 620, 630 also, still we are not doing -14. We are doing up to -10 if the Paki is too high. Still, if it is more than -8, still my first preference is going to be the phakic lens only. Then you are showing about your chart about between 40 to 50. If is moderate myopia, always my preference would be presbyond. I have done thousands of presbyond, which phenomenal results. Almost today 15th year follow patients are coming. There is absolutely no problem. In my case, myopes doing extremely well. Only few hypermetropies coming with their distance vision is very good. They started developing their because of probably lenticular changes, started developing near vision. But presbyon results are amazing. Again, all this refractive lens exchange, multifocal, I've been telling in most of the podium, I follow the one thumb rule that no patient's dominant eye. If you make your dominant eye proper, like make them emmetropic, you play around with the non-dominant eye, still you can go with that. So one good example what I did for my mother, I operated almost around 15, 16 years before with the monofocal. Always she used to grumble with me. What I cannot cook only because of you. I can see distance, but I wanted to cook. Cooking is my passion. Then for the left eye, what I did, I put a multifocal. She is very happy. I knew that her right eye was dominant. So by knowing, because the concept behind all this press beyond is knowing your dominant eye and making the non-dominant eye myopic and creating a spherical aberration in both the cornea. So we started doing similar kind even in the lens base. One of the company, no financial interest, that is RMB lens from Rayner. We started using that. The patient doesn't want a glare and halos. So we make dominant eye sharp emmetropic, making non-dominant eye myopic by one diopter. Patient started getting now N5 also. Again, dominant eye knowing in all this refractive patient, I feel very, very important.
Very true, sir. I also sometimes do that. Regarding the press beyond, I don't know, I have not done the press beyond, but I have some experience with the supracore when it was introduced. That was like, I did nearly 100 eyes probably during the period 2013 to 15. Their recommendation at that time was only hyperop with presbyope. They didn't have the myopic protocol at that time, so I didn't do. And during the last part of those cases, we did emmetropes with presbyopes also. As you said, initial only 1 or 2 patients had unsatisfactory result, but now I see many of them are coming back with presbyopic.
See, basically supracore, sir, it is a more of a hyperopic treatment. Rather here the concept is creating a spherical aberration in both the cornea. But supracore making the cornea to treat for each eye for distance, each eye for near also. That's what the concept they say that. It makes the patient, it mainly works even on the pupil size also, that is one, and more of a hyperopic. That is the reason this one has, the importance of supracore has come down in the market. Rather nowadays most of the companies working on this Q value, that is Alcon working on this Q value. Again Swint has come up with the Presby Max, again creating the spherical aberration in both the cornea. By creating a spherical aberration in both the cornea, you will have the depth of focus, the patient will have increase in the depth of focus, they will have a very good near vision. So you have to create a spherical aberration, probably most of the patient negative spherical aberration up to 0.5 diopters, then patient do very well.
And in the SMILE, when you get a regression, what is your next, how do you do
patient,
enhancement?
see now they are like, we have got circle software also. If they are having a very good packy back, then you can use the circle software, you can make the flap, then you can do examiner touch upon. Or if it is like a 0.75 -1, still you can do PRK, come out with that. They're on the pipeline to know about the secondary SMILE. I think soon within a year or two, I think they'll come with a secondary SMILE. Cap within cap they want to do. They are trying that. I think hopefully they should come. But if you are grossly, suddenly some patients might have left behind -3, -4, if they develop, if they are having a very good packy. Best is circle software. The same circle software, if you enter the patient data, the cap will convert into flap. Then just lift the flap, that's all. Then you do the examiner, the results are phenomenal.
Okay, but you are losing the advantage of
Flapless.
non-flap size.
Flapless. In such case, best is PRK. Of course, as she said that PRK, again coming back, especially some of the machines are too good with the single step PRK, especially I think Swint what they do. Normally what Swint do is it first treat the stroma, then later with the epithelium. So the advantage is much better. Even MEL 90 also good machine, but you have to go with the PTK mode, then take out the epithelium, then you can again do a PR. Again, all results are, because all these are flying spot lasers, the results are pretty good.
So I think most of the machines are coming up with that option. Even EX500 is also having that streamlined PRK.
Yeah.
We are winding up the session. Once again, thank you for all the speakers.